Hi, my presentation is on chikungunya. This is an RNA virus spread by a mosquito vector and largely in tropical and subtropical climates. The name roughly means that which bends in a Mozambique language, and it describes the stooped, bent-over appearance of patients presenting with painful arthralgia. Early cases have often been misdiagnosed as dengue or other related diseases, with first documentation of outbreaks as early as the 1770s, though this was not able to be confirmed because the disease was not sero-isolated until the 1950s. And that was during an epidemic in Tanzania. The disease is considered endemic in Asian Africa, though outbreaks have been occurring in expanding sub-countries worldwide. Chikungunya strains were isolated during large urban outbreaks in Thailand in the 60s and in India in the 60s and 70s. More recently, the spread has been attributed to increased air travel and carrying the disease by viremic travelers. In 2004, there's an epidemic in Kenya that spread throughout the Indian Ocean islands with 500,000 cases by summer 2006, at which time it spread to India, infecting almost 1.4 million people in that year alone. Viremic travelers then spread from India, spread the disease from India to the Andaman and Nicobar Islands, Sri Lanka, the Maldives, Singapore, Malaysia, and Indonesia. By 2007, in northern Italy, concern was rising because the virus was now found to be spreading autochthonously, meaning from an infected human gets bit by a mosquito, which then turns around and bites another human and spreads it that way. So from human to mosquito to human vector. In 2010, continuing cases were reported in most of these countries, and the disease further spread to Thailand, Taiwan, France, the United States, Martinique in the Caribbean, and French Guiana, also all attributed to spread by viremic travelers. The most recent outbreak is the ongoing epidemic in the Caribbean, with the first case reported on St. Thomas in late November 2013. This current disease has been the first known cases of the autochthonous form in the Americas. Transmission signs and symptoms. Mosquito vectors are the transmission vectors of this disease. Humans are the primary reservoir during epidemic periods, with several vertebrates, including non-human primates, rodents, birds, and some small animals identified as potential reservoirs during inter-epidemic periods. The mosquitoes will incubate the virus for about 10 days, bite humans, and symptom onset in humans occurs after an average incubation period of 3 to 7 days. A single exposure is believed to provide lifetime immunity, and roughly 3 to 28%, depending on the study, of those testing positive for chikungunya antibodies will have an asymptomatic infection, though can still spread the disease. Those with symptoms can present acutely, subacutely, and/or with chronic symptoms. Chronic symptoms are listed there. The acute phase lasts for 3 to 10 days. After 10 days begins the subacute phase, with chronic symptoms defined as those beginning at 3 months. Chronic symptoms, the incidence of chronic symptoms is variable. Studies report persistent symptoms ranging from 12% to as high as 93% of patients, though in the latter studies this declines to 47% by 2 years post-infection. Diagnosis is through these various laboratory tests, and for the most reliable or accurate diagnosis, it's recommended that serum is collected both immediately after symptom onset and again during the subacute phase. Differential diagnosis is also important, as fever with or without arthralgia is common to multiple diseases, including malaria, dengue, leptospirosis, rheumatic fever, and other alphaviral infections. High-risk groups are those living in close proximity to mosquito breeding areas, or areas with standing water, predominantly man-made standing water, immunocompromised, or patients with comorbidities, and the very young and elderly also are more likely to have a greater risk of severe disease presentation. There is limited risk with pregnancy and no evidence to date that the virus is transmitted via breast milk. Prevention strategies are limited to personal protection, which is centered around avoiding getting bit by mosquitoes, and vector control on a more regional level. Insecticides alone are of limited use in population control, primarily due to the development of resistant strains throughout the world of the vector species. Additionally, most interventions now center around reduction of breeding areas and addressing standing water. The mosquitoes are characterized by a preference for feeding on human blood and the ability to lay eggs in man-made water containers such as rainwater collection barrels, tires, and yards, etc. Over the past 25 years, there's also been established success with the use of cephalopoid colepods in standing water supply in eradicating or nearly eradicating populations of Aedes aegypti and other strains of vector mosquitoes in multiple locales, including Vietnam, Tahiti, Hawaii, and Thailand. And the colepods will eat the larvae of the mosquitoes. Sterile insect technique was developed in the 1950s with ionizing sterilization, releasing sterile males into the general population. This has proven expensive and with limited efficacy. More recently, the release of insects carrying a dominant lethal gene has been trialed and is more promising. It's a female-specific promoter that's repressible by antibiotics tetracycline, so once mosquitoes are released, they're no longer exposed to the tetracycline, and the transgene is activated, eventually causes death of the mosquitoes. This technique has been used successfully in several species, including Mediterranean fruit fly, and has seriously reduced populations of Aedes aegypti in Brazil, the Cayman Islands, and Malaysia. So it does show some promise in addressing the chikungunya vector. Case management. There's currently no specific treatment for chikungunya and no commercially available preventative vaccine. The main intervention is protection against mosquito bites. And treatment is limited to addressing presenting symptoms. It's symptomatic or supportive treatment, and they're such as ibuprofen, NSAIDs. Aspirin is not advised to the risk of bleeding in a small number of patients. Increased fluid intake is recommended, and there are some studies on the benefits of short-term corticosteroid use. The use of netting to prevent and minimize spread from infected persons to the general population is also advised, as well as community-level management, including establishment of in-place protocols for triage care and rehabilitation of patients.